Well, hello everyone, and welcome to the Family Caregiver Support Program weekly training and education program. This week's topic is on hospice and palliative care. My name is Michelle McGuire. I'm a case manager with the Family Caregiver Support Program. And at this time, I'd like to introduce the rest of the Family Caregiver Support team. We are led by our program manager, Amy Blackburn, and I'm joined by my case manager colleague, Olga Yamawaki. I'm going to start right in with what's the difference with hospice and palliative care. What I find is that a lot of people don't realize there's a difference, and they kind of think that palliative care is the same as hospice, that they're synonymous, and they're not. They definitely share a lot of similarities, but there are some significant differences, as you will see. Palliative care or comfort care is care that relieves symptoms of a disease or disorder, whether or not it can be cured. Hospice care is a specific type of palliative care for people who likely have 6 months or less to live. I really like this graphic because I really like the definition it gives for each of these terms, and also it really shows you the relationship of hospice care to palliative care. Palliative care is a broad category, and again, it includes improving life quality for patients with serious illness. I'm going to introduce another term here, end-of-life care, and that is for those entering the last phase of life, when it's clear that you're going to be succumbing to your illnesses. That's when you enter end-of-life care. Now, hospice is a type of end-of-life care, and it's the model for delivering end-of-life care that is most common in our country, and that is because it works. So again, I want to show you that hospice is part of palliative care, but palliative care is actually a much broader category than hospice or end-of-life care. And you won't see this term anymore through the presentation. I'm just going to focus on the differences between hospice and palliative care. And also mention some of the similarities. Now, palliative care is specialized medical care for people with serious illness. The goal is to reduce pain and suffering, and it can begin at diagnosis and continue through treatment. Hospice care, on the other hand, is specialized medical care for people with terminal illness rather than serious illness. The goal is to reduce pain and suffering. It begins after treatment has stopped, as opposed to palliative care, which can begin at diagnosis. It begins after treatment has stopped and when it's clear the person is not going to survive the illness, which is generally 6 months or less. Both palliative care and hospice care provide comfort. The palliative care focuses on your physical well-being, your intellectual, emotional, social well-being, and your spiritual well-being. So your palliative care team will be made up of physicians, physical therapists, and nurses who will take care of your physical well-being, psychologists, social workers who will address intellectual, emotional, and social well-being, and a chaplain who's there for any spiritual needs that a patient may have. Now with hospice care, the care is centered on the patient and the family. The hospice team will help the family members understand, prepare for, and support each other through the final illness. And hospice care also optimizes the quality of life by anticipating, preventing, and treating the suffering of the patient. Your hospice care team will be comprised of physicians and nurses, home health aides, social workers, counselors, and volunteers, and also a chaplain. These are just some examples of health conditions that are appropriate for palliative care. Cancer, heart disease, kidney failure, stroke. You can see a lot of these people can recover from. They're not necessarily always fatal. Well, some of them definitely can be. Symptoms that can be improved by palliative care: pain, nausea, anxiety, depression, constipation. These are just a few. Any symptom that somebody with a serious illness has is going to try to be addressed by the team. If they can't do it, they probably try to find other resources. So it really is just focused on making the patient comfortable and meeting their needs, whatever that may be. Now, I'd just like to go over a little history of palliative care and hospice. I think this is very interesting because hospice actually came first and palliative care came second. which is kind of interesting when you think about the graph. So for hospice, it's a Latin term, hospitum. It means hospitality or place of rest and protection for the ill and weary. And it's believed that the first hospices were in Malta way back when, and these were for specifically to care for the ill and dying as they were traveling around to and from the Holy Land. So hospices were extremely popular in the churches and monasteries throughout the 1600s. That's primarily where they were. The ill would go to the church through the 1600s. And with the Reformation, church kind of lost a lot of power, a lot of central organization, and government started to take over more of the healthcare operations and whatnot. And they started providing for people at end of life. They started building buildings for, hospitals for people to come for the terminally ill. But it took a while. You see, the U.S., it took till 1974 before the first hospice funding legislation was actually passed. So it's been around for a long time, but it took a long time for it to become standardized and supported, at least from our government's perspective. Now, the history of hospice and palliative care. Okay, more continuance here. I'm sorry. This is back to Europe. This is 1967. Cicely Saunders was a nun, and she's credited with developing the first actual hospice. It was St. Christopher's Hospice for the terminally ill. And at the same time, over here in the US, Elizabeth Kubler-Ross published her seminal work called On Death and Dying, and that described the phases that people go through psychologically when they're dying. And this guy, this urologist, Balford Mount from Canada, he was following Elizabeth Kubler-Ross and Cicely Saunders and was very interested in their work. And he opened up his own palliative care ward in a hospital in Canada in 1973. So then 1987, the Cleveland Clinic Cancer Center in Ohio was the first developed the first training and research program for palliative care, and also was the first hospital to offer palliative care services. So for example, if you go to the hospital, you might get cardiac services, you might get oncology services, you might get surgery, all these different services of medical care, and palliative care was a service you could go actually get from the Cleveland Clinic in 1987. So some benefits of palliative care. I just want to mention some notable research outcomes that I came across. There's evidence that hospital palliative care consult teams are associated with significant hospital and overall health system cost savings. So palliative care saves money. There's evidence that palliative care services increase the likelihood of dying at home and reduce symptom burden without impacting on caregiver grief. So basically this says that using palliative care increases the likelihood you'll die at home, which is a good thing, and without affecting the caregiver in a negative way. There's also evidence that providing palliative care in tandem with standard oncology care among patients with cancer is associated with lower rates of depression, increased quality of life, and increased length of survival compared to those receiving standard oncology care. So hospice care really works, and it has a lot of really beneficial outcomes. But there are some issues. The current issues with expanding palliative care. Well, we know that the baby boomers are aging, and we know that there is going to be a strain on our healthcare system and our healthcare resources. And this is very true in the case of palliative care. Palliative care going from the hospital into long-term care facilities, which is where it is kind of projected to go, home and into the long-term care facilities. The long-term care facilities, they're not equipped to handle it. The patient profile in that setting is changing considerably. We are becoming more frail. We're living with more comorbidities longer, which presents a more complex care plan for the staff. They have to be better trained. And also long-term care facilities need to become more hospice-like, because we do use that model. And if people are using long-term care facilities for their long-term care, they're going to end up needing hospice. So again, long-term care facilities, they're not equipped to handle the large capacities that are coming, the volume, and also the complexity of the care. Staff is not trained for the complexity of care, the facilities, equipment, and also the government regulations regulating long-term care facilities need to change before any of these changes can be implemented. So some of the solutions to address these issues, we need to build infrastructure. We need to change the long-term care regulations, and we need funded studies for research and development on how to develop the infrastructure, the computer platforms, the training, everything has to be determined in advance, and research and development is the best way to do that. Staff training is a big issue. How do you train people on the job? And that's kind of what it's going to have to be. And currently, the training for palliative care in long-term care facilities is targeted to physicians and nurses, which is not very effective because, in fact, the certified nursing assistants and the medical assistants are the ones who end up spending the most time with the patient, yet they're getting the least amount of training in their care. So palliative care at home rather than in a long-term care facility. Again, the current model is hospice, but again, it only kicks in when you've got 6 months or less to live or when you're in end-of-life care. So palliative care can start way before hospice is appropriate. Some of the issues are the same for hospice as we will have for palliative care. Equal access to resources. Not everybody has access to a hospice team right now. And I guess one of the big divides is urban versus rural healthcare systems. That's just one issue. And that's going to be the case for palliative care as well. Equal access to resources. Also, one thing that's going to happen is standardized models of care for palliative care. And this is going to have to happen regardless of where it's given. We need to have national standards for pain control methods, and medications, treatment models, expected outcomes from palliative care, and again, training. So there's a lot to do, but it's exciting because it really stands to benefit us greatly if we can implement palliative care models. Just want to leave you with the research findings again. Adding palliative care services to long-term care facilities resulted in significant reductions in length of hospital stay, significant reductions in hospital admissions, and decreased costs. Okay, that's just some research finding. We didn't even touch on how helpful it is to the patient or the family there. So with that, I'm going to open it up for questions or comments.
Michelle, did you find much in your reading on the differences between each as far as what's covered through health insurance?
Yeah, right now health insurance, I just have general knowledge on this. Health insurance most will cover hospice. Pretty much everybody will cover hospice if you get the doctor's note that you have less than 6 months to live.
Right.
Palliative care is a lot harder. Not everybody's covering it, and getting coverage is difficult. So I think that's part of this expansion, is that it needs to become more of a standard model of care.
Yeah, because I was thinking that's the only way that they can standardize a model is if they do cover the payments rather than it being mostly private pay.
Yeah, because they have to be able to control the data and all that.
Yeah.
And
a lot of times families, like everybody that I've talked to about their loved one's situation, where it sounds to me like you can kind of tell when you're talking to people when their loved one is at end of life stages, yet the doctor, and I've found this to be a huge issue, the doctor does not like to bring up hospice, and they won't bring up hospice, and the families have to be advocates for their loved one in bringing it up to the doctor and kind of pushing to get the hospice approved a lot of times. Unfortunately, in most cases, in my experience, by the time the family member is able to talk to the doctor about it and get hospice implemented, the family member ends up dying within a few days or like a couple weeks. And it's lucky that they were on hospice for that little bit of time. But when you think about that, somebody should have been on hospice like 6 months before, you know.
Yeah.
That's the problem. And that's why when you bring it up to families and they say, oh, well, I didn't think it was until they were at the very end of life. No, 6 months is a long time.
Yeah, it is.
To have that covered and have the quality of life for everybody, the family member, the entire family, everybody involved, just improved quality of life at the end of life, if it is the end of life in 6 months. Because a lot of times when people are on hospice, they actually improve after 6 months.
Yeah, yeah, and it's still covered. That's something that I read, that it's still covered, even if it's okay. It'll be covered even if you live.
Right, exactly. Well, they'll be reevaluated and then put on for not like another 6 months type of thing. Yeah. Like I've known people on hospice for a year and a half because they get reevaluated every 6 months and it just keeps getting extended. But the thing is, hospice is so effective that it improves their quality of life, and they do actually improve in that time. And the thing is, you never know if they would have declined in that time, and maybe they would have passed away. So that's the important thing that people need to understand as far as hospice. It's not like the very, very end of life.
Right. And palliative care is not the same as hospice. When you say palliative care, I think a lot of people just, they think that's what you're talking about. But no, so many of our clients care recipients have serious illnesses and can benefit from palliative care.
Yeah.
Yeah. And I think, Michelle, you also touched on the training for doctors. I think a lot of doctors don't know the difference between also hospice and palliative. So I think why a lot of times they don't recommend it, because they don't know what to tell the families. They're not getting training. So I see that a lot of doctors. That's why a lot of families don't hear that from the doctors. The families have to be requesting it.
Yeah, I know there are some organizations or some training programs that are starting to, bring in the end of life discussions and train the doctors how to do that. And is it the POLST form that addresses this?
Yeah, that's one of them. Could be a healthcare directive in general.
Yeah.
So.
But I think you're right. Definitely the reluctance of professionals to discuss it, or their discomfort with how to discuss it. Yeah.
Yeah, and then sometimes having a team, like you mentioned, the hospitals, having a team that comes in, and discussing that with the family.
Yeah. They do have palliative care teams, but I think it just needs to be so much more widespread. And again, that's just going to be legislation and funding.
Yeah. Yeah, and the other thing I've heard from family members, when they talk to their doctors about it, the doctor will say, well, I think palliative care is appropriate for now, but not hospice. And that just tells you right there, well, you obviously don't have an understanding of each one. But yeah, every situation that I've talked to families about it, the family member ended up getting on hospice, but then dying within weeks. So the doctor obviously wasn't.
With all the efficacy of palliative care, it just seems it just makes so much more sense to start it as early as possible, because you can alleviate so many of the problems.
And like you said, it avoids a lot of medical costs, instead of having the care recipient ending up in the hospital so many times during the 6 months. All that could have been avoided.
Yeah. And the caregiver too.
Yeah.
Right. Another thing I was wondering when you mentioned long-term care facilities, I know that hospice can be an assisted living, but can there be hospice in skilled nursing too?
I think that's what the issue was, is that they
Oh,
need to transfer in to be able to
ah,
give hospice.
okay,
There may be some of that going on now, but it needs to be more formalized.
okay,
Yeah, usually from what I've heard is a hospice company will come into the skilled nursing to render the services.
Yeah.
But it's an outside company as opposed to the skilled nursing
right,
of facilitating the services. Yeah.
yeah, okay,
One of our clients was actually maybe going to do that.
okay.
I probably shouldn't talk about that here.
Hospice can't be done in the hospital though, so they would have to transfer out of the hospital first, be discharged from the hospital into some type of either care facility or in the home.
You said can't be done?
Nope.
Makes sense operationally.
Mm-hmm.
Yeah, we have the capacity to make some fantastic changes.
Yeah, it'll be interesting to see what happens.
Yeah.
I wish there were more people on this call, like some of our clients and stuff. Hopefully, when we get the recording up online, people will watch it. People just, they're, I guess, they don't really like to hear about it, type of thing. They don't think
There
it
might be.
applies to them, or they don't want to, they think we're just going to be talking about death the whole time. That's what they kind of associate hospice with. So,
Yeah.
but
Yeah.
to me, it's all about quality of life, and that's what it is really.
Yeah.
For everybody, it's like what you said, how it relieves the stress and burden of the caregiver and the families.
Yeah. Yep. It's good stuff.
Mm-hmm.
Well, I will encourage my clients to come and watch this presentation.
Good. Yeah, and then mentioning the pulse and healthcare directives, that actually might be another good presentation. Maybe I'll do that for the next one, because that one people tend to have a lot of questions about.
Mm-hmm.
So.
Yeah, that'd be great. Okay, if that's it, I'm going to go ahead and stop the recording.